so for everyone to show up. Okay. All right. So it's a quick, nice lecture. So stroke is actually, as we know, is a really devastating event happens to any family. And most of the times it's actually acute, unexpected event. So as it's important as we have, as we going to explain how should we consider it for our patients. So when we say stroke, we think about two different entities. Number one, which is ischemic stroke, and number two is hemorrhagic stroke. So the thrombotic stroke could be a thrombus, or sorry, the ischemic stroke could be a thrombus or emboli caused stroke or related stroke. So the blood supply is actually blocked to a certain area of the brain due to thrombus formation or due to emboli that traveled through the arterial system and blocked certain branches of the cerebral artery, either the anterior, the middle, the posterior. When we think about the hemorrhagic stroke, there is actually hemorrhage, like bleeding, internal bleeding, and it's affecting the brain, not by only ischemia. I mean, when it's actually oozing the blood out, then the blood is not reaching the targeted tissue. So that there is ischemia, but on the other side, it's also increasing the pressure inside the brain due to the bleeding itself and due to the edema from the ischemic tissue. So it's worse when you think about the mechanism. So let's think about the brain distribution. So we have the anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery. And what would help you in understanding where to look when you do the CT. So in the emergency room, you do the CAT scan, plain CAT scan of the brain without any contrast. It should be done within 10 minutes, even though the ACLS and the BLS recommendation to have the patient on the table for the CT within 10 minutes, but the read can be released in within 24 minutes. But for the best practice to save the patient, you probably put your target to have the CT ready and you read it within 10 minutes. So you look at the CT and you, according to your assessment of the patient, when the patient arrived to the emergency room, you have concern about certain areas in the CT. And that's what we're going to talk about now. So when you have a patient with lower extremity weakness more than the upper extremity, then that should make you, especially if it's unilateral. So unilateral weakness of the right leg or lower extremity and minimal weakness in the upper right extremity with some urine incontinence or bowel incontinence or some confusion, then that should make you think about anterior cerebral artery stroke, ischemia. The areas that supply with blood to the anterior cerebral artery is affected here. That's why the patient is presenting this way. If you have someone comes to the emergency room with actually a right or left, let's say left upper extremity weakness and left lower extremity weakness, but it's more with the left arm and the face with the facial drop, facial drop in the left side. So that would make you feel like there is actually involvement in the middle cerebral artery. So the middle cerebral artery would affect the upper extremity, affects the ability to speak. So they would have aphasia if it's affecting the dominant side of the brain. If it's affecting the non-dominant part, it will give you, and it's really, you could miss this neglected side because the patient would not say, I'm neglecting this side. They would just act weirdly. Let me tell you, I had a case of such neglected side because of the middle cerebral artery stroke. She was a 65-year-old female, came into the emergency room with her husband saying that I couldn't make sense of what she's saying, and she is pointing with her leg toward something in the drawer in our like our um, room at home, and I feel like she is just confused. When we start talking to her, she is just looking to the right side. She was ignoring the left side. Even when she looked, like she wouldn't keep her vision to the other side. She just assuming. So that's the thing. That's what you should make sense out of. She is just assuming that there is only one side, and she used the other side for anything she wanted to do. And when you ask her to raise her legs, raise her arms, she would just ignore you when you ask her to raise the other side. If you think that she is unable to move it, then that's the problem. You have to insist that please move this side. Don't assume that they couldn't move it, that's why they're not moving it, because that might be neglected side. They are not moving it because they're neglecting it. Okay? So keep that in mind. Posterior cerebral artery stroke. So yeah, here, when you have the level of the stroke is posteriorly, and the posterior cerebral stroke is really different than the anterior and the middle. It affects the temperature, the pain. It can have the shifting, so it's affecting one side and the other. You also have the Horner-like syndrome, so they have the pupils is like a constricted, meiosis, ptosis, and anhidrosis. So when you have a brain bleed, actually, the pupil will be dilated. It's the opposite to the Horner. So you have a brain bleed, then the patient have dilated pupils in the affected area where the bleeding is happening. But with the Horner syndrome is actually the meiosis. Is actually a pinpointed pupil where you actually have the affected side. And the dysphagia, the 4Ds, really important. Dysphagia, diplopia, dysarthria, and dysphonia. So these are affected with the posterior circulation. The 4Ds, really important. Okay. And the transient ischemic attack. So when you have decrease in the blood perfusion to certain areas of the brain for a short period of time, that would affect the ability of the patient. So it's not actually complete obstruction, is actually narrowing and decreasing the blood supply. Let's say I have an elderly patient and have atherosclerosis, and his cerebral and cerebellar arteries really narrow because of the atherosclerosis. So it's narrow to start with. Then the patient did not drink water and not eat for the last 12 hours. So the patient will be dehydrated. So the blood supply will be affected everywhere in his body, including the brain. Then the patient will start having some symptoms related to decrease in the blood perfusion. So it's ischemia, but not due to complete occlusion by thrombus or emboli or actually bleeding. No, it's actually just because he's not getting enough blood supply to the affected area. As soon as you improve the blood supply by improving the giving IV fluids and give and like aspirin, if it was only related to this, then the symptoms probably would improve. Or even the patient drink more fluids at home and he will come back. Or you put him in supine position. So the position of the brain is actually close to the, like the, not against the gravity, is actually with the gravity. So that would also help the blood perfusion, then symptoms would improve. So keep that in mind. But the other thing to also consider, the patient might have mild symptoms and you think he return or she returns back to normal, even though you see the patient for the first time. So be really cautious. You don't know the baseline for this patient. You have no idea if he actually or she returned back to baseline or not. Assuming that they are able to move the organ, that doesn't mean that they're actually back, or the symptoms actually of like sensory loss or something improved. That doesn't mean that they improved every single part of the affected tissue in the brain. They still might have a small terminal thrombus. So the thrombus could travel distally and block really small artery. And that area that was supplied by this small blood vessel will be affected. But it's a very small area. So you might feel like the patient returned back to normal, but the patient did not. So that's why be very cautious when you say transient ischemic attack. I would keep the patient for observation. I would do echo to see if I have any atrial fibrillation caused the thrombus to travel from the heart to the brain. I would do the ultrasound of the carotid arteries to see how narrow is the carotid artery, if it's stenotic or not. I would probably consider MRI next day to see if the patient actually have terminal thrombus that I could not see with the CT and CT angio I did when the patient arrived, that the MRI might help me with. Okay, so transient ischemic attack is not something easy to call. You should be very comfortable that the patient returned back to normal before you call it a transient ischemic attack. All right, assessments. So the history, you take the history, make sure that you ask all the questions according to your concerns. You also, so one of the mimics for stroke is actually hypoglycemia. As you all know, we always check the glucose for someone is actually having some stroke kind of symptoms. Also a seizure, the post seizure like state, which is that sometimes lead to Todd's paralysis, also can be a mimic for stroke. Sepsis, as I said, sepsis could present with anything. If it's affecting the brain, then probably he will have some stroke symptoms that would be actually confusing. And also think about the other causes and be sure to differentiate between stroke and syncope. Okay. So think about the other. So if you have, as I said, the hemorrhagic stroke, you would expect your patient to have headache, right? Because the pressure inside the brain is really shooting up because of the hemorrhage. So I would expect most of my patients with a hemorrhagic stroke to come present with some headache and increased intracranial pressure related symptoms, right? So yeah, I want you to keep in mind those things when you evaluate your patient in the ER or in any settings where you suspect an acute event happened. So your physical examination, you check the vitals, you do the neuro exam, a comprehensive neuro exam to check for any neurogenic deficit. So you check for the motor, sensory, cranial nerves, the gait of the patient, and you also need to do all the like tests, the special tests you do, the pronator drifts and all the other possible helping tests, including nystagmus to check for nystagmus, which is really important, and it's a cerebellar related stroke. CBC, check the CBC, check the white count, check the platelets, and also you need to check the glucose, check the electrolytes, hyponatremia. As we said, hyponatremia could present with confusion. So you also need to check that, check the kidney function, if anything affected the kidney function, and check the PT, PTT, and INR before you decide about like giving anticoagulant or anything like that. You guys hear me? I just want to make sure that you're still hearing me because I had a phone call a little bit ago. All right. And acute stroke, low risk. So you do, for the imaging, you do a plain CT of the brain to see if you have hemorrhage or not. So the first thing, you rule out hemorrhage, brain bleed, intracranial bleed. As soon as you rule out that, then you consider doing the CT angio immediately, even if you don't have the kidney function. If it's urgent, if you're still in the window, you would definitely consider doing the CT angio. What I'm saying here, the window and outside the window, this is a big topic. I think we're talking about here. Yes, here. So it's you have a window where you can interfere and you can actually manage with some intervention. And when you pass the window, it's a little bit risky to try any intervention. And you try to do conservative treatment after that point. So you also need to check the other possible causes. As we said, you do echo, you do the carotid ultrasound. So the management, you do the ABC, oxygen, IV access, as you always do with any patient that might need acute intervention in the emergency room. Keep the patient monitored all the time. Check the blood pressure. You want the blood pressure to be like a little bit to the higher side, but not to the point it's really high, because that would be one of the contraindication of giving TPA. All right, consult the neurology, get the stroke team alert. So do the stroke alert. And you do the glucose check at the beginning and start the IV fluids as you can. Then you do the CT. CT came back negative for bleeding. Then you do the CTA. CT angio showed possible ischemia. Then you call and make sure that the patient is in the window. When we say in the window, you have two different windows. The window for the thrombolytics is 6 hours, and that is dramatically changed. We started with 3 hours, then 4.5, and now we're up to 6 hours for the thrombolytics. And for the intervention is actually up to 12 hours. So if you're considering this patient is eligible according to your assessment for thrombolytic, so the start of symptoms happened less than 6 hours ago. And this is really the most important question when you assess a patient with possible stroke. When did the symptoms started? So when did the whole thing happen? And this is really critical because sometimes your patient woke up from sleep with the symptoms. So here you have no idea if that happened a second ago or when they went to bed, or like you have no idea. And those are elderly populations, so they would probably have multiple comorbidities, and they might be bedridden. So keep that in mind. And also sometimes they come to you and they say, oh, okay, the nurse or the caregiver of this patient came to like take the patient to the bathroom, and she or he found the patient to have this and or that. So actually, the patient could not tell you when did this happen, and the caregiver have no idea if that just happened or happened hours ago. So here, be cautious to call it happened when they realize it's actually happening. You have to keep in mind that might happen long time ago. So this is why this question is really critical, because the decision you make accordingly is different. So when you have this confusion about this, the time of the symptoms, then you go back to when was the last time the patient was normal. They would say probably before he went to bed, he was normal, or before I left him at this time, the patient was normal. So you used that as the time before the event happened. You don't use the confusing part as the time when the patient has have symptoms. So you always be cautious, because if you take the patient to the OR or the cath lab, sorry, with the concern that actually it was more than 12 hours or 24 hours, then you're actually making a big mistake, because complications would be a little bit more. All right, so you consider the appropriate treatment according to the window, and you treat the patient accordingly. You also make sure that you ask all the possible contraindications for any of those two treatments. All right, so the TIA, you give the fluids, you give aspirin, and you do the like workup, including, as we said, the CT angio and echo and carotid ultrasound. You also need to start the patient on aspirin. So the primary, you check the CHAD score. Do you guys know the CHAD's 2 score? There is a CHAD-VASc score now. Actually, it's not now. It's been there for a while. So it's actually, C is for congestive heart failure. H is for hypertension. The A is for the age above 65. And the D is for diabetes. And the S is for stroke, previous stroke. And every single one of those will take 1 in your score, and the stroke will take 2. That's why CHAD's 2. Okay. And secondly, oral anticoagulants should be started according to your assessment. All right. So let's go to the next lecture. All right. Save a second here. So we'll talk now about alternative status. Okay. All right. Where is it? Interesting. Okay, so let's get started. We'll talk about the alternative status, approach to alternative status in the emergency room. So the change in the neurological awareness from baseline mental status. So there's a change in the mental status of the patient. The baseline is different from every patient to the other. It can be acute, so if it's actually happening in hours to days, and it can be gradual. So is it delirium or dementia, right? Because both could cause alter and change in the mental status of the patient. Is the patient drowsy, lethargic, or actually the patient is in coma? These are questions you have to ask, like severity of the altered mental status. So the initial intervention, you need to make sure that always your patient check the airway, breathing, and circulation. Make sure that you address all of that. Check the vital signs, IV lines as needed, and the immediate check of the glucose, because we know that hypoglycemia can present with altered mental status. And you check the oxygen saturation, because hypoxia can also lead to the altered mental status, and hypercapnia also can lead to altered mental status. Protect your airways, especially when you have unstable patients. Check for signs of shock. Do we have hypotension, cold extremities, weak pulse, delayed cap refill? Yeah, cap refill is not really used much in the emergency room, but yeah, it's one of the actually things that you can use. Consider starting IV fluid. If you feel like the patient is going through shock, you can give fluid bolus. But keep in mind, you need to check the heart for the pumping function, the ejection fraction of the heart, if the patient can handle the fluids you're giving or not. This is really important. All patients with the altered mental status need rapid glucose check, as we know, yes. And you consider give D50 for hypoglycemia. So assessment, you take the history, or ask all the questions you should ask to check for possible trauma, especially when you have an elderly patient who woke up in the middle of the night while going to the bathroom and suddenly tripped and fall and come to you with altered mental status. This is a brain bleed until proved the otherwise, right? Because they probably take some anticoagulant medication and they hit their head to the ground and they probably have brain bleed. So these are the questions about the trauma you probably need to ask. Onset, evaluation, duration, you have to check when did the whole thing start, or what happened, why, and all the related questions. If the patient have fever, you think about what it was. Okay, so for fever and it's a brain infection, it's encephalitis or something else. Let's see, it's meningitis. Sorry, yes. So is it encephalitis, meningitis? And you also have to ask about headache. As we said, if you have a brain bleed, you would have a severe headache, especially with subarachnoid hemorrhage. Definitely that would give you the worst headache. And you ask for questions about increased intracranial pressure, including nausea, vomiting. And you ask about the diarrhea. If the patient is actually dehydrated, you should ask about diarrhea. Shortness of breath and polyuria, polydipsia, things related to diabetes. And you ask about the recent illnesses, if there's recent infection or exposure. Any medications, ask about the possible medication for hypertension, and things might cause the patient to, if they miss dose or something, might have a hypertension emergency or something like that. Exposure to snake and spider, yeah, you should probably consider that if it's altered mental status and you're concerned. Possible ingestion, yeah, in intoxication and withdrawal symptoms, yeah, if you have someone like with opioid overdose or maybe withdrawal symptoms for any medication that would cause the patient to have a change in the sensorium, you should ask. And you consider a tox screen for those patients. Assessment, you do the physical examination, check the mental status, the Glasgow Coma Scale for trauma. So it's a trauma related test. We probably, if someone, you're not suspecting trauma and ask you for GCS, you say probably it's not really helpful in such case, but I would tell you the GCS if you want. So always keep in mind GCS is a trauma score that's used, not like for someone with no history of trauma to be assessed. Deviation, nystagmus, yeah, if the pupil is reactive or not, the motor and sensory. You do the focused exam for the etiology if you're suspecting hematoma, laceration in the scalp. You check for those in case the patient have history of trauma, head trauma. Fever, you check for hypotension, signs of septic shock. Respiratory difficulty, if the patient have difficulty with breathing, hypoxia and hypercapnia also can lead to altered mental status. As we said, if the patient is actually pregnant, think about HELP syndrome. And HELP syndrome is actually is not that common, but when it happens, is a nightmare for your patient with preeclampsia. Ask about the eclampsia, if the patient had seizure or something, because that would change the level of consciousness, seizing, and then they have the paralysis and the confusion afterward. Ask the questions about skin infections, bed sores, rashes, and cellulitis, and that can cause septic shock, as we know. Smell your patient. If the patient, you feel like the patient have like the ketone smell, like a DKA kind of breathing, rapid shallow breathe or something like that. Just keep it also in mind, because you're always check the glucose for any patient with altered mental status. So that would give you a hint about the possibility of DKA. Unilateral weakness. So yeah, if the patient have weakness, obviously you probably should think about stroke. So
Doctor?
Go ahead.
Hello?
Who's trying?
I got a
Yeah,
question.
yeah.
Sorry for interrupting you. Could
Yeah,
we
go ahead.
consider neuremic syndrome and hepatic encephalopathy?
Uremic syndrome and hepatic definitely, yes, that's a really good question. Yes, those two should would affect the level of consciousness. True. And that's one of the things that you need to consider. And if you have the concern, the patient have chronic liver disease and they come with altered mental status, and you have concern that they might go through like increase in the metabolites that actually toxin in the blood, that also something you need to consider. And what would you do for the patient with the liver cirrhosis, hepatic
Can we give them
encephalopathy?
lactulose like?
So you give the lactulose to get rid of the toxins, but also what else you need to check? You need to check something in the blood. Ammonia level. You need to check the ammonia level.
Ammonia level for sure.
Yep. Excellent. Excellent. Okay. So we go to the differential diagnosis. And you ask the patient about alcohol, and that's also with the liver cirrhosis. So you ask about alcohol abuse and any alcohol-related encephalopathy that might be happening. And check the epilepsy and also the seizure history, and you consider it in your differential diagnosis. Electrolyte disturbance, including the sodium, especially sodium and calcium. And you also consider hypothyroidism, and as we said, hypothyroidism and myxedemic coma and thyrotoxicosis, both the core symptom is actually altered mental status, as you guys remember, and hepatic encephalopathy, as you just mentioned. So definitely that's one of your differential. The insulin, hyperglycemia and hypoglycemia. So keep that in mind too. Overdose, like if the patient have opioid overdose or organophosphate poisoning. Hypothermia, patient present with hypothermia would also have alternate status. I think the spelling is not right. Hypothermia should be. Uremia, so yeah, renal failure would also lead to altered status. Trauma, yes, subarachnoid and subdural, all they are possible brain bleed could cause altered status. Infection, meningitis, abscess. If you have someone with chronic sinusitis and have recurrent episodes of abscess and he's not getting antibiotic treatment, not considering any treatment for that, then the patient might have brain abscess. Okay, encephalitis. Psychiatric, yes, yeah, but it's the last one to keep. Like you always do rule out all the possible causes, then you diagnose psychiatric related. It's a diagnosis of exclusion. You never say this patient have bipolar or schizophrenia by meeting the patient for one time in the emergency room. You always rule out the other possible differential diagnosis. Then you say, okay, we rule out everything. I probably might be related psych issue. So it's the last one to think about. Stroke, and that's, as we said in the previous lecture, it can cause altered status and all the other brain mass occupying lesion can cause increase in the pressure in the brain and also can cause change in the level of consciousness. So your investigations, you do CBC, check the electrolytes. As we said, CBC, you need to look for certain things. Electrolytes, you also need to check that all the electrolytes you're concerned that might cause altered status. Check the kidney function because your uremia could lead to that. Check the glucose, malaria. And so malaria is really not that common, but you also need to consider it if you're having someone from endemic area. So keep that also in mind. Liver function for the hepatic encephalopathy. Thyroid function, definitely for myxedemic coma and thyrotoxicosis, cerebral spinal fluid analysis for brain infections. And you also check the images. So you do CT brain, rule out bleeding, and you also need to consider MRI and other related imaging according to your suspicious. If you're suspecting something in the brain, you do the appropriate imaging for the brain. If you're suspecting something in the abdomen, if you're suspecting a pneumonia like causing septic shock, you need to do the X-ray, then you consider CT. So according to your concern and your differential diagnosis, you go with your workup. So the management, it depends on the etiology of the altered status, but always keep in mind ABC and keep the airway and patient and the breathing and the circulation to be okay. So stabilize the patient, resuscitate your patient. So if the vital signs stable, should then start the workup to rule out the differential diagnosis you have in your mind. And if the patient is unstable, then you have to start resuscitation and consider taking the patient to another hospital if you are in limited circumstances. If you are in the right hospital, then you start resuscitation, stabilize your patient, then start the investigation according to your plan. All right, thank you all. We are all set now. Do you want us to go back to that video so you guys can see the video? Let me just go back. I will stop sharing the screen now. And I will go back to, let's see, questions. أعتقد يا مهدي أنت ساعدتنا المرة الماضية في الفيديو، لو ممكن تساعدنا هذه المرة. Okay. All right. The whole video. أرسل لكم إياه على الشات الرابط ولا okay. All right. Okay. All right. هوقف سكرين شيرنج فتقدر انت تعمل سكرين شير معانا. خليني اشوف اذا كملت بالبارتيشن. اوكي اوكي بيرفكت.
Man, am I hungry.
مو هذا الثاني هذا.
Yeah, I'm starving. I was thinking about ordering hamburger.
مو الأول الثاني توك في الصفحة نفسها الثاني. إيه هذا patient presentation. Yes.
Welcome to your emergency medicine rotation. We're glad to have you join us. Today, we want to talk about one of the fundamental skills in emergency medicine, patient presentations. Now, you'll notice there are features about the emergency department that shape the way we present. Things here happen very fast.
Medical patient, room 3, now.
The acuity is very high.
Trauma team, room 1,
yes,
now.
Please take him to room 1. I will be right there. And there tend to be multiple distractions. Excuse me. Yes, patient's INR is 7. Got it. Thank you so much. Absolutely, I agree. Thank you. Definitely STEMI. Let's activate the cath lab right away. Thank you. So, in order to be able to function in this environment, we have to make sure our presentations are concise, organized, and focused on the emergent issues. There's a presentation going on right now. Let's see how it's done.
Hi, Dr. Mitra?
Yes.
I have a patient I'm ready to present whenever you're ready.
Sure, go ahead.
So I just saw Mr. Ferguson. He's over in room 4. He's a 64-year-old male. He has a history of osteoarthritis of the left knee, anxiety, high blood pressure, glaucoma, diabetes, carpal tunnel syndrome, hyperlipidemia, and gout that mostly hits his right great toe. His pain started a few days ago when he was drinking tea. He typically drinks chamomile, but he had run out and got some peppermint and thought perhaps that was what was going on. On social history, Mr. Ferguson doesn't smoke. He does drink the occasional glass of dry red wines, and he lives at home with 2 pet chihuahuas, and their names are Honey and Bear, which I thought was just kind of cute. On exam, Mr. Ferguson is in no acute distress. He has blue eyes. His neck was supple. There was no cervical adenopathy. It's definitely not anything cardiac. I mean, he looks really, really well. Dr. Mitra, you have a pulse? Doctor, I need a doctor.
Perhaps that was not the best example. Let's talk more about how to present in the ED. Presenting is not about restating all of your findings. Rather, it should be a synthesis of your findings to help shape future medical decision-making. Now, there are different ways to conceptualize this process. The one we want to share with you today is to think about presenting like telling a story. Now, like any good story, your presentation should have a beginning, middle, and end. Your beginning is your introductory statement that contains the patient demographics, the pertinent past medical history, and the reason for the visit. The middle of your presentation is the crux. It's where you develop your characters, which in this context are the disease conditions you're considering, either because they carry high probability or high risk. And your ending is your differential diagnosis and management plan. Now, it's important that your presentations do not read like a mystery novel in which your audience is completely clueless about where the story is going and what's going on. Instead, your differential diagnosis is the focal point upon which to build your narrative. In fact, your listener should be able to anticipate your differential diagnosis based on the preceding narrative. Your introductory statement sets the stage for the rest of the presentation by making the reason for the visit clear, as well as creating a backdrop or frame for the conditions that your patient may be at risk for based on their predisposing factors. So let's go back to Mr. Ferguson. He's a gentleman with diabetes, high blood pressure, high cholesterol, and arthritis. Let's say the reason for his visit is that he was found unresponsive with a blood glucose of 20. In that scenario, you want to highlight that he's a diabetic patient who's on an oral hypoglycemic agent. If, however, the reason for his visit is that he developed severe lip swelling, then the items you want to pull into your frame is that he has high blood pressure and that he's on an ACE inhibitor, setting the stage for angioedema. Notice that in either scenario, his high cholesterol and arthritis are not relevant, so they do not necessarily need to be presented. You're using your ending to help shape the beginning of your narrative. The middle of your presentation is the crux in which you develop your characters, which in this context are the disease conditions you are considering, either because they carry high probability or high risk. In general, you want to think early about the life and limb-threatening conditions to use them to help shape your assessment. So with chest pain, think about the myocardial infarction, the pulmonary embolism, or the aortic dissection, even before you walk into the room. If it's right lower quadrant pain, think about appendicitis, ovarian torsion, or ectopic pregnancy. The earlier you start considering these do not miss diagnoses, the better you'll be at looking for them and using them to shape your narrative. Now, each of these characters also have their mini stories, which are the classic presentations or patterns of disease. So for example, with unstable angina, it's the new or accelerating chest pressure that's worth with exertion and better with rest. With appendicitis, it's the migratory right lower quadrant pain that's associated with fever, anorexia, and nausea. You want to be proactive in looking for these patterns of disease early on to help organize your findings. So rather than randomly present the quality of the pain, the radiation of the pain, or the severity of the pain, extract and organize them into a way that fits within the mini stories of the disease conditions you are considering. So in general, in emergency medicine, we don't use the headings of past medical history, family history, social history review systems. Rather, we incorporate the relevant items from each of these topics into one big historical narrative. So the pertinent past medical history gets incorporated into the introductory statement. The relevant items from the review systems becomes part of the mini stories for the disease conditions that you are considering. For medications and allergies, you should always obtain them and review them with your patient. However, there may be some practice variation about whether you should represent them in total or review them together in front of the electronic health record. For physical exam, vital signs should always be presented, and you should highlight abnormalities, or otherwise you can globally refer to them with terms such as unremarkable. Be sure to describe the general appearance of your patient, and for the remainder of your exam, you can use the reason for the visit as well as the differential diagnosis to decide what is pertinent and what is non-contributory and can be excluded. If there's any available data such as EKG, labs, or radiographic studies, you can present these as well, but once again, focusing on items that inform your differential diagnosis. Your ending is your differential diagnosis and management plan. In other words, what do you think is going on with the patient and how do you want to manage their care? It's important that your differential diagnosis is not a random list of diagnostic considerations, but rather should be stratified on probability and risk of harm. So one such classification scheme is to start with first, what do you think is the most likely diagnosis? Or, especially with critical care patients, what is the imminent diagnosis that must be readily addressed? Secondly, present the high risk or do not miss conditions that may not necessarily be the most likely, but still need to be excluded. Thirdly, are the do not miss diagnoses that you have considered, but yet you feel have been excluded this time based on your history, physical exam, and initial data. It's important that you at least consider these diagnoses, otherwise you run the risk of missing them. So you should always regard the conditions that pose risk to life, limb, or reproductive ability in your differential diagnosis. Lastly, you have the option of presenting conditions that pose low risk and are also of low to moderate probability. Your management plan can be divided into diagnostics, therapeutics, and disposition. So different institutions may have nuances in terms of how they like things being presented. But this concept of thinking about your presentations as telling a story will help you make them more concise and a synthesized version of your findings that prioritizes the identification and exclusion of do not miss diagnoses. I think our doctor has been revived, and our student's going to try again applying these concepts. Let's go see how it goes this time around.
Hey, Dr. Mitra?
Yes.
I'm ready to present a patient whenever you are. I learned a lot from last time.
Me too.
Okay, so Mr. Ferguson is a 64-year-old male with a history of diabetes, hypertension, and hyperlipidemia who comes in with a chief complaint of chest pain for the last 3 days. He described it as a substernal burning, and he gets about 5 to 10 episodes a day. He first noticed it after he was drinking some tea, but then he's also had multiple unprovoked episodes as well. The pain is neither exertional nor is it pleuritic, and it doesn't radiate to his back or anywhere else. He does get some shortness of breath with the pain, but he doesn't have any nausea, vomiting, or diaphoresis. He doesn't have any leg swelling, fevers, cough, or abdominal pain either. Mr. Ferguson takes glyburide, lisinopril, and simvastatin. He doesn't have any drug allergies, and he doesn't smoke. On physical exam, Mr. Ferguson's vital signs were unremarkable. He's comfortable and well-appearing. He doesn't have any JVD. His lungs were clear. His heart exam was with a regular rate and rhythm without any murmurs, gallops, or rubs. His abdominal exam was benign, and he did have intact and symmetric distal pulses without any lower extremity edema or tenderness. His EKG is here. I looked at it, it looked like it was in normal sinus rhythm without any acute ischemic changes. For my assessment and plan, Mr. Ferguson is a 64-year-old gentleman who comes in with multiple cardiac risk factors with the chief complaint of substernal chest pain. For my differential, the fact that the pain is burning and he notices it mostly after tea makes me think of something GI like reflux as the most probable diagnosis, but he does have multiple cardiac risk factors and he has had the spontaneous episodes of pain as well, which make me concerned enough that we should rule out the acute coronary syndrome. He doesn't have any pleuritic pain or any signs or symptoms of DVT to make me strongly suspect a PE. He doesn't have any tearing pain, he's normotensive, and he doesn't have any pulse deficits to make me strongly suspect a dissection either. For my plan, I'd like to get a CBC, a BMP, a set of cardiac biomarkers, a chest x-ray, and give him aspirin. Currently, he's chest pain free, and we can reassess the need for further analgesia later. For disposition, Mr. Ferguson, if his first set of enzymes comes back negative, I'd still like to bring him into our chest pain observation center to complete a rule out and get a functional study in the morning.
Great assessment and good plan.
Thank you.
There you have it. There's nothing like a great story and a well-crafted, concise presentation. Thank you for joining us.
excellent. عندكم أي أسئلة تحبوا نتكلم فيها قبل ما ننهي اللقاء اليوم؟ إن شاء الله بالتوفيق. اختباركم متى إن شاء الله؟ سمعت إنه اختباركم قريب. يلا بالتوفيق إن شاء الله. راح يكون تفضل.
Hello. I get a question regarding stroke management. Like, can you get a case scenario that how we can approach a patient coming within a window and a patient coming out of the window?
Sure.
Or during the window?
Yeah, sure. So let's do actually a real case I had. So I had a patient coming with his wife. He was a 62-year-old male. According to his wife, about 6 hours ago, they were sitting in the living room, and she went to bring him his breakfast, and he was confused if she was his wife or someone else when she arrived with the food in her hand. So he said, who you are and what's wrong? And he was speaking like really with a little bit different kind of tone of his voice. So his wife was like, hey, I'm here. What are you talking about? I'm your wife. So he said, I see like if you are two people, not like one person. So here, what does that tell you? Like as a physician, he have diplopia, right? So he see two different people coming to him and he was confused what's happening. So that's one of the 4 Ds when he presents. So she said 6 hours ago exactly things happened, and now he's a little bit confused. His voice is a little bit different. So if you go back to the 4 Ds, dysphonia, one of them, and diplopia is one of them, right? So this is a posterior circulation related ischemia. So you do the full examination, you talk to the patient, you do assessment, you have the patient moving all the extremities, no sensory deficit, but he would be like, I feel cold. So he would say, I feel cold, and mainly in his right lower limb, and you're not sure if it's actually a pain or temperature sensation related or something else. But you definitely, when you do the eye exam, for the patient, you will notice that the patient have a sixth cranial nerve palsy. So he's not able to move his eye laterally. So and it was affecting the right eye only. That's why he developed the diplopia. So he is 6 hours from the beginning of the symptoms. So, and it was witnessed event by his wife. So that's why you can say this is 6 hours. It is still in the window for the intervention. And you call the stroke team, do the CT. So as soon as you activate the stroke alert, and you do the full assessment in 5 minutes or so, check the glucose, and take the patient to the CT. CT done, you don't see any bleeding in the brain. So that's, you ruled out bleeding, and you also now you focus on the possible posterior circulation ischemia that happened to that patient. So you call the neurology. Neurology arrives. You also order the CT angio. As soon as you call them, you order the CT angio to do the CT angio and to see where it exactly affecting him in the posterior circulation. So neurology came down, they evaluated the patient, they agreed with your assessment. They looked, the patient went to the CT angio was done. You look at the CT angio, you see the area where it's actually involving in the posterior circulation. Then the neurology physician will decide according to the criteria. If the patient is not having any exclusion criteria, they will take the patient to the cath lab. Sounds good. This is a patient in the window. If the patient is like 5 hours ago, then the patient is eligible also for the thrombolytic therapy. So the neurology will decide to do either the thrombolytic or to do the intervention through the cath lab.
So, doctor, what I infer from your talks as ER consultant, I am not responsible for giving thrombolytics. Yeah.
Yes, in 90% of the times, you are not the one to give the thrombolytics. In few cases, if you are in underserved area, you have no neurologist in the area, and you will need to transfer the patient to another facility, and or the patient will be outside the window by the time the patient reaches the other facility, then you are the one to decide giving the thrombolytics or not. And here is the time when you go over the exclusion criteria, and you do the whole scoring system that we use for the stroke, then you can give the thrombolytics. But in most of the times when you have a backup neurology team and stroke team available, it's better for the patient safety and for the patient care to have the neurology team decide about the thrombolytic for such case. Okay.
So thank you so much for your kind and well clarification. It's well understood. Thank you.
يلا يعطيكم العافية وبالتوفيق. وأنا محاضراتي زي ما أنا أرسلت للدكتور ريهام. حتى بعض المحاضرات نفس المواضيع بس محاضرات قديمة شوي، ممكن تطلعوا عليها، بس ما راح يخرج إن شاء الله الاختبار عن الأشياء اللي تكلمنا فيها في أثناء المحاضرة والمكتوبة في السلايدز. بالتوفيق جميعا، في أمان الله.